commonly hypertension involves, occasionally we get the diastolic is normal, but the systolic is very high. If it is, okay, so isolated systolic hypertension is when the systolic blood pressure is more than 160 and diastolic is normal. Faham? All right. Now, so these are the classification of severity: mild, moderate, and severe. Okay. All right. This is easy. Now, we revisit what are the, in order for us to understand how blood pressure, increase in blood pressure comes about, we have to understand the factors controlling blood pressure. And this you have done in physiology, right? What are the factors that control blood pressure?
Cardiac output.
Cardiac output times peripheral
resistance.
resistance. Okay, every time your heart pumps during diastolic, of course, the blood goes out. Okay. Now, what affects cardiac output? It's your blood volume, and your blood volume is, of course, controlled by certain factors, right? No? Yes. For example, sodium retention, sodium homeostasis, right? Because with sodium comes water. And then we know that what are the factors that control sodium reabsorption, right? Sodium balance in your body. For example, your mineralocorticoids and the kidney, right? Now, and then of course you have your cardiac factors, heart rate and contractility. And for peripheral resistance, you have factors that control peripheral resistance, humoral factors, whether they are constrictors or dilators, neural factors, again, constrictors or dilators, and then of course you have autoregulators. Okay, now this is just a reminder of you, for you, what you've learned in the previous year. Now, we know that the kidney is very important in controlling blood volume, right? Right? You have your mineralocorticoids, but it's a kidney is the site where your sodium goes out and sodium goes back into the body. Okay? So the renin angiotensin mechanism or system is very important for the control of blood pressure. Ingat tak? Ingat? Right. Where is renin produced? Okay. I pretend or I assume that I heard the right answer. So if the answer is wrong to you or to your friend can correct you. Okay. And renin release is affected by reduced blood pressure and reduced renal blood flow. So any factors or anything that reduces the blood pressure or renal blood flow will stimulate renin, and hence renin will lead to angiotensin, which it itself is a vasoconstrictor, and then of course it leads to release of aldosterone, and aldosterone then will reabsorb sodium. With it comes water, and it goes back to your body to try to balance, to try to get back the blood pressure. Okay, so this is how the kidney controls blood pressure, but things can go wrong where the blood pressure cannot go down. All right, okay, clear. This is just a revision. Okay, all right, we've said that, yeah? Sodium homeostasis again. Okay, and then you have GFR independent natriuretic factors, and then you have renal depressor substance. All these effects, it goes back to sodium reabsorption and the maintenance of blood pressure. I don't want to spend too long. If you've forgotten, you go back and read yourself. Now we come back to why is it that you and I don't have hypertension, and why do other people develop hypertension? Okay, now basically you can divide systemic hypertension into primary, or it is also called essential. Okay, basically because we do not know the cause, we do not quite know the mechanism, although we have theories, but we cannot pinpoint the cause, and therefore difficult to treat. We treat the blood pressure, but we don't treat the cause. Okay, so this is called essential hypertension, which is the commonest. If you hear your parents of having high blood pressure, it falls under this. Okay, so the commonest is essential hypertension. When you see the word essential, it means primary. It means there is no cause. Okay. Number two, the other group is secondary hypertension. When you say secondary, there is a cause, secondary to something. All right? Okay. Now, 5 to 20%, we know that hypertension is very common in the population, and hypertension is a disease that constitutes 5 to 20, that affects 5 to 20% of our population, and majority of them are essential. Let's talk a bit, where we're going to talk a lot more on essential hypertension, because this is the one that you are going to see as doctors in your clinic, in the hospitals. They are the ones who are coming with the effects of not getting treated properly. Okay? So the effect of sustained, prolonged increase in blood pressure, so they are the ones you're going to see. Because the secondary one, if they go to you, you can treat them because you know the cause. You can get rid of the cause and they don't come back to you. So the hypertension is treated. But these affect the older generation. Dia tak makan ubat, dia tak pergi follow up, dia tak dengar advice kita. Okay, they will come back. They will have chronic hypertension, and then the day they will come back with organ damage. So we're going to see afterwards how high blood pressure destroys the organ. Okay. I sakit tapi raja. You all kena semangat macam I lah. Demam sikit pun kena datang.
Baik.
Demam ni. Now, primary hypertension, commoners, 90 to 95% of all cases of hypertension constitute essential hypertension, usually occur after age 40. So it is the age of the, it's related to age. Okay, it has a familial tendency. Okay, meaning if you have a family history, you have a tendency to get it. Not necessarily you get it, but you have a tendency to get it. Occur as a primary phenomenon without known cause, and there are risk factors, and that's important to you as doctors. You have to know what are the risk factors, because you're going to advise your patients. You're going to advise your mak saudara, pak saudara, parents to make sure that they don't develop one. Okay, so the risk factors for essential hypertension can be divided into two groups. One is modifiable, meaning you can modify, right? Which is difficult. Okay? Obesity is one. Okay. Number one is increased salt intake, susah. Suka makan garam, banyak. Orang Kelantan suka makan pudu, so masin. The Japanese likes to eat a lot of salt, so they have increase in the incidence of essential hypertension in their population. Alcohol abuse, of course, alcohol is almost always related to almost everything. Lack of exercise, meaning sedentary lifestyle. Okay, they don't exercise. maybe executive yang duduk dalam bilik buat kerja and with added stress. So these are risk factors which are modifiable. Faham? Okay, that's why we always encourage healthy lifestyle. Very good. Unmodifiable ethnic group, race. You can't change your race, but there is a tendency, right? They say that the African Americans and Asians have a tendency to develop essential hypertension. Hereditary, if it is in the genes, you can't get rid of the genes, and of course, age. Yeah, age. The risk is higher in older age group. Mechanism, we do not know the mechanism. So don't worry about this slide. I'm not going to ask you in exams what is mechanism. As long as it is a theory, you are not required to know as a CLO, but you are required to know as a knowledge. You want to be able to explain, agak macam ni, kalau your parents ke, your auntie, uncle tanya you, you say these are the possible things, but we're not sure. Okay, possibly a genetic defect in renal sodium excretion, or a genetic defect in sodium calcium transport in vascular smooth muscle, variation in genes encoding the angiotensin, testinogen. Okay, there may be other increased vasoconstrictive influence, or there may be abnormality in the nitrous oxide system. So okay, forget that, right? Just why you are taking up medicine, because you want to know how these changes affect your patients, and you're going to, by understanding the effects and complications, then you will learn how to treat them, how to manage them, right? So what are the effects and complications of systemic hypertension? Now, prolonged, sustained high blood pressure. I mean, if you have high blood pressure today and then it goes down tomorrow, no, there are no effects. We do get our pressure goes right up, right? We'll be anxious. Betul tak? Yeah. So we're talking about chronic, long, sustained patients with essential hypertension. They will be their blood pressure will be high forever. Okay, managing is to reduce the blood pressure because you do not want this to happen. What are the effects? It has effects on blood vessels. High blood pressure, prolonged, sustained, chronic changes give rise to pathological changes in the blood vessels. Okay, you have all kinds of blood vessels, right? You have large blood vessels, for example, aorta, the medium size aorta, your iliac arteries, pulmonary arteries. Then you have the medium size, and then you have arterioles, and then you have capillaries. Now, prolonged sustained blood pressure will give rise to changes in all these various arteries. Okay. Now, in the small blood vessels, okay, it leads to what you call hyaline arteriolosclerosis, meaning there is changes in the wall leading to hyaline material deposition in the wall of the artery. Arteriolosclerosis is a terminology related to pathology of the blood vessel, but exactly what it is hyaline deposition. Therefore, the wall is thickened. The what happens when the wall is thickened? The lumen is narrowed. Betul? Just bayangkan longkang kalau dindingnya menebal dengan tak tahu apa lah, dengan your pipe tu menebal dengan minyak dengan apa, dia akan tersumbat, ya. So narrowing. So the key word here is hyaline. This is very specific for hypertension. Hyaline arteriolosclerosis. And the other change is hyperplastic arteriosclerosis. There'll be more changes. We'll see afterwards. And the third is it can lead to fibrinoid necrosis. So these are the three changes. These are the three pathological changes that can occur in patients with prolonged chronic sustained hypertension. Now, these changes um, are different, basically based on the severity of the disease, because hyperplastic and fibrinoid necrosis are found in patients with really very high blood pressure. We'll see after that. Yeah? Now, these are the changes and these are the effects, right? Because of the thickening of the wall, it leads to vascular narrowing. Vascular narrowing or obliteration lead to reduced blood flow. Reduced blood flow leads to reduced oxygen delivery to that organ, and therefore it can lead to cell death. Cell death as a result of reduced blood flow is called infarction. Ischemia just means reduced blood flow. Okay, infarction is when the cells undergo necrosis because there is no oxygen. Faham? Alright. Will the organ be damaged? Yes. And this is give me a common example. A very common example. People dying every other day or every day.
Myocardial infarction.
Sorry?
Myocardial infarction.
Myocardial infarction, heart attack, because the coronary vessels are affected, right? Thickened, reduced, narrowing, and that part of the heart that is supplied by that coronary vessel will undergo myocardial infarction. Okay. Number two, this high blood pressure not only causes thickening, but it can damage the wall. And this is a fibrinoid necrosis. Yeah? The wall itself the cells lining the wall of the arteries can die. Okay, fibrinoid necrosis, damage. So you have thinning of the wall, and it can cause weakening of the wall. When the wall of the vessel is weakened, it can lead to formation of aneurysm. It can dilate. Aneurysm means dilatation of the vessel. Aneurysm, microaneurysm. And this microaneurysm, because the wall is very weak, it can rupture. It ruptures, it causes hemorrhage, and it causes infarction as well, because there is no effective blood flow in that area. The blood is all out in the tissue. So can you give me an example? Can you give me an example before we go? Where can it bleed in patient's hypertension? Sorry? Which vessels where can they bleed? Whereas in the heart, it's more of obstruction. Myocardial infarction is obstruction. Microaneurysm and bleed where? Selalu dengar.
Stroke.
Huh? No, small blood vessels. The aorta is big. In the brain. The small blood vessels rupture in the brain and they get stroke. You dengar selalu orang dapat stroke kan? Orang tu so and so dapat dah lama dah high blood pressure, tension, tapi dia tak makan ubat, tak follow up, dia baru dapat stroke. Doktor buat CT scan, ada brain hemorrhage. Okay? Okay. So those are small blood vessels. But hypertension can also affect changes in the large blood vessels and the medium-sized blood vessels. Like you say, for example, aorta and the other arteries that are that the other medium-sized arteries. So what are the changes? Hypertension lead to degenerative changes in the large and medium-sized blood vessels. And what are these degenerative changes? It is atherosclerosis.
Baru tadi.
Kan? So hypertension can lead to formation of atherosclerosis in the large and medium-sized blood vessels. Do you know what's atherosclerosis?
Yes, deposition.
Why do you think there is hypertension leads to that?
Lot of
Injury
lipid.
to the intima. There's an intimal damage. Initially, there must be an intimal damage. Then that leads to subsequent deposition of lipid peroxidation and subsequent deposition of lipid and smooth muscle proliferation, leading to necrosis and so on and so forth. Atherosclerosis is number one killer. So hypertension is one of the risk factors, and that's very reason why you have to advise people to not develop high blood pressure. Okay, just to have a look at eyeliner. Okay, highline. These are just examples. Okay, kidney is one organ where the blood vessels affected will finally lead to kidney damage. I've said just now, hyaline atherosclerosis, right? So this is an example in the kidney. Microscopically, you see muscle hypertrophy, thickening of the media, and deposition of a hyaline material, which is a homogeneous thickening of arterial walls with loss of underlying structural details, which finally will lead to intimal fibrosis and narrowing of the lumen. Now, hyaline can be seen in hypertension, which is not so severe. Okay, not so severe but prolonged, and usually we refer this as benign hypertension. This word benign nothing to do with cancer. Benign just means it is not so severe. Okay, so changes seen in benign hypertension. So this is how, look, there is hyaline deposition, thickening of the wall, narrowing of the lumen. Okay, all right. Now, the other change is the hyperplastic arteriolosclerosis. Now, this change occurs in the more severe form, and if it exceeds a certain blood pressure, we call it malignant hypertension. Okay, we will see what is malignant. Okay, hyperplastic arteriolosclerosis in arterioles, also described as onion skin. Okay, the appearance is slightly different. If we look under, it is called onion skin because the appearance is like a concentric laminated thickening of vessel walls. We can't see under light microscopy. You just can see this onion skin changes, but under electron microscopy, they can see laminations consisting of smooth muscle cells and thickened basement membrane. Okay, so that's the changes. The other one is more of deposition of hyaline. Here is more of laminations of smooth muscle cells and thickened basement membrane, which can only be seen under electron microscopy. Okay, again, it leads to narrowing of the lumen. And much later, again, this is related to malignant hypertension. There will be fibrinoid necrosis. There is damage to the wall, necrosis with fibrinoid material deposited. Okay, now this is characteristic of malignant hypertension, severe hypertension. Okay, see, It looks different, right? Right? This is just laminations of smooth muscle cells and thickened basement membrane, which we see under EM. Here, this is just highline deposition. Okay? Now, okay. Now, this is a special mention, malignant hypertension, meaning whether when the BP is very, very high, you know, yeah, usually when the patient is not compliant to treatment. All right. Now, very, very high BP is a medical emergency. Okay, and these patients clinically they will show a blood pressure of more than 200 over 140. Now, this is classified as malignant hypertension, and patient will develop changes in the eye, which is called edema of the optic disc, which is called papilledema, and patient will have uh, uh, blood, red blood cells in the urine, what you call hematuria. Okay? Other clinical manifestations, patients may come in with hypertensive encephalopathy, changes due to changes in the brain. They may be drowsy, they may go into coma, they may have severe headache and they're very irritable. Okay? Renal failure, patients may have disseminated intravascular coagulopathy, patient may be in heart failure because high blood pressure leads to heart failure, right? Left heart failure, right? Okay. And of course, pulmonary edema, and some of them may have acute myocardial infarction and ischemia, all related to systemic effects of high blood pressure. So, but the definition here is blood pressure of more than 200, systolic, 140 diastolic, and commonly papilledema in hematuria. Okay, so that's malignant hypertension. Now we're going to see the effects of these vascular changes on specific organs, because yeah, you're going to say tak boleh kena makan ubat nanti kidney pakcik rosak. Inilah dia. Kidney pakcik tu rosak sebab changes in the small blood vessels and will lead to renal damage. Okay? Vascular damage leads to progress. Initially, it may just be proteinuria and it may progressive to renal failure. Chronic, have you done renal failure? Oh, not yet. Chronic renal failure. That means all your nephrons are gone. The kidney is gone. You cannot treat. You manage by dialysis, but you want to treat, you have to do a transplant, give him a new kidney. Okay? So basically because of the changes that we see just now, right? Ischemia, systemic contractility. See? This is what it looks like. Contracted kidney, contracted, but there are some areas. Okay, this is what a chronic kidney disease due to a secondary to hypertension. Bilaterally contracted, finely granular appearance in the kidneys. Is granular because granular dia ada yang timbul, ada yang tak timbul. Dia timbul, dia tak timbul. Dia nampak macam granular kan? Because yang tak timbul tu ada scar tissue. Dia dah berparut, dia tak timbul. Okay? Accentuates the areas yang belum affected. Okay, protruding bumps. So areas of atrophy and scarring with contraction alternating with normal areas. So classically, this is the description of chronic kidney disease secondary to hypertension. Contracted and granular. Okay, we've seen this. Okay, how about the central? We have blood vessels all over, right? And the small ke, big ke, medium ke, apa ke, it's present everywhere. So we are interested in the effects and complications of the vital organs. Therefore, it can affect the brain. Okay, how about the brain? I told you in the brain, the small vessels, blood vessels, or the penetrating vessels of the brainstem develop aneurysm, small aneurysm, and they have given it a name, Charcot-Bouchard aneurysm, microaneurysm. Okay, in the small blood vessels or the penetrating vessels of brainstem and midbrain. The small blood vessels that penetrates your brain substance. Okay, it can rupture and it can lead to intracerebral hemorrhage and infarction. The key word is aneurysm. What? Small blood vessels in the brain matter leading to intracerebral. Kita ada macam-macam blood vessels in the brain. What? You have the bigger arteries, medium-sized arteries, your circle of Willis. They are not in the brain. They are outside the brain matter. So other diseases affected that area. But for hypertension, it's the small penetrating blood vessels in the brain that are damaged, that becomes aneurysmal, and they rupture, and therefore they cause intracerebral hemorrhage. Is it easy to treat? No, because it's in the brain. Dia bercampur dah dengan. That's why it's almost always that the patient, if small patient would develop stroke, if big patient would die. But for example, if you develop a subdural hematoma, boleh je hidup because we can drain. Okay? Faham? So when you do CNS, you would learn the different types of brain hemorrhage depending on which vessels are affected. Okay? Stroke or cerebrovascular accident, also called hypertensive encephalopathy, where the BP is very high. Of course, patient develops speech and vision problem, maybe paresthesia, disorientation, leads loss of consciousness. Okay, that's one. When it comes to this part of the head, body, the hypertension can cause changes in the intracerebral vessels. The other one, it can also affect the bigger vessels, your carotid vessel, that brings the blood to the brain. Okay, so since it's bigger, so it's considered as a middle size, it can be affected by atheroma. Alright? So they can get transient ischemic attack. They can get changes in the carotid vessels and kadang ada atherosclerosis. Sometimes it throw off a bit of a plaque, dapat emboli, and patient get a transient attack. But then the patient will recover. Okay? Are you with me?
Yes.
This is to show you brain hemorrhage. Okay, the other organ is the eye, because you get small blood vessels in the eye. Right? Small blood vessels in the eye, in the retina. That's why when you become doctors or when you go to clinicals, you will learn to use the ophthalmoscope to look at the changes in the retina, because disease can affect retinal, give rise to retinal changes. Now, of course, hypertensive retinopathy involves, again, the blood vessels, arterioles narrowing, moderate narrowing of the blood column, narrowing. So the lumen is very narrow. You can see the blood. Kalau you guna ophthalmoscope, you can actually see the vessel. You can see blood flow. So the blood flow tu becomes very narrow lah, sebab dia dah constrict kan. So they give it a name, copper wiring. Medicine suka bagi nama. Okay. If it is moderate, they call it copper wiring. If it is severe, they call it silver, not sliver. Silver narrowing. So very narrow stream of blood flow because of the narrowing of the. And then you have arteriovenous crossing abnormalities. The artery crosses the vein and it causes kinking. Kinking apa ya? Pressure on it. So dia nampak kink. Terpenyek, macam terpenyek. Kinking. So this you can see with the ophthalmoscope. So arteriovenous crossing maknanya the arteries crosses the vein. Because dia berat, dia tebal, jadi dia memenyekkan the vein. So that you can see. You can use your ophthalmoscope and see. Okay, normal people don't have that. So this is called arteriovenous nicking or nipping. If it is severe, of course, those arteries again, small arteries, capillaries can rupture and leads to hemorrhage. And this is described as red shape. And then, of course, with hemorrhage, no blood supply there, it can develop necrosis, infarct, right? And fibrosis. Okay, you can have infarct, which is called soft or continuous oxidate, and of course, there is edema of the optic disc. If it affects the macula, the person can go blind. Now, all these changes are related to changes in the blood vessels. Okay? Blood vessels. These are all is a consequence of changes in the blood vessels. Okay, this is what you see. Okay? But these are just infarcted area, white area. This is hemorrhage. Okay? I can't see kinky. Alright. Okay, of course you know the effect on the heart. What is the effect on the heart? Left ventricular hypertrophy. Initially, left side has to work so hard, becomes hypertrophy. Lama kelamaan, it will dilate. It may be big. The cells may be big, but after a long time, it will not be effective. Okay, it will dilate, and when it dilates, it doesn't contract anymore. Then you call it left ventricular failure. Left ventricular failure will lead to
aneurysm.
if the left ventricle fail to pump, what happens to the blood?
Ischemia.
Okay, low cardiac output backwards. Low cardiac output meaning patient has heart failure. They have heart failure. Backwards, what happens to the blood? Come on now. It doesn't go on. It's not there. It's not there.
Congested.
What happens? What happens to, there is an obstruction to left ventricular outflow. Left ventricle is connected to?
Aorta.
Left ventricle is connected to?
Aorta.
Where does the left ventricle get the blood? Where does the left ventricle get its blood?
From the vein.
Left ventricle. Left atrium. Left atrium. Where does the left atrium get its blood? Pulmonary vein. Okay, what happens is this flow from the pulmonary vein comes from the lung, right? So what happens?
Lung congested.
What happens?
Lung congested.
Sorry? Keluar sikit.
Congested.
Tak dengar? You all ni, this is basic.
Lung become
What happens?
congested.
Nothing happens. Nothing happens to the lung.
Lung become congested.
Sorry?
Lung become congested.
Congestive.
Congested.
Why?
Because the blood cannot flow to.
Why? Explain in a scientific way. Why?
Because
What happens to the blood in the atrium? Tak boleh jalan juga. What happens to the blood in the pulmonary vein? So what happens? You have just learned edema, you know. So what happens to the pulmonary vein? Pun tersumbat juga kan, tak boleh keluar kan. So it goes back to the lungs. So in the capillary end, where it channels the blood to the primary vein. So what happens then?
Increase in pressure.
What pressure is increased?
Hydrostatic.
Hydrostatic pressure. You just learned edema. Concept is the same. It does not matter where you apply it. System. You've got the capillary, you've got the veins. If the veins is congested, the hydrostatic pressure in capillary venous end will be increased. What happens when it's increased? Fluid will flow out. Where does the fluid flow out in this instance? In the lungs. So what does the patient get? Pulmonary edema. That's very, very important. Pulmonary edema, will the patient live if you don't treat patient? No, it's just like you're going to the pond and get yourself drowned. You've got fluid in your lungs. You will die because you don't get oxygen exchange. So that's a very important effect. I didn't write here, but that's a concept you can understand on edema. Increased hydrostatic pressure because of venous obstruction, whether this is a pump failure, right? So the back pressure, there's an increase in back pressure. It's all connected. Okay, I want you all to go back and rewrite again and remind yourself. Okay. Of course, it is implicated in pathogenesis of dissecting aneurysm of the aorta. In atherosclerosis, ada dissecting aneurysm. High blood pressure, if the patient has got atherosclerosis of aorta, if the patient develops high blood pressure, it can split the wall of the aorta. So the wall now has two lumen. So that's why you call it dissecting aneurysm. The high blood pressure can split the damaged atherosclerotic wall. Are you with me? Okay. This wall is split. So you have a lumen in there and you have another lumen here. Is that good? No. All this aneurysm and rupture. Okay, very important. This is just to show you thickening of the wall. You see this? Okay. Okay, those are the important organs. Try to make you understand it. Back again and read on edema. Edema doesn't mean that it can happen only systemic. Edema can be only. Okay, I want you to go back and read again because I think you all are not getting the concept on edema right. Make it simple. If you don't understand, you can come and ask me in the next turn. Make it clear. Now, I don't have very many minutes, but we are going to go through causes of secondary hypertension. Now, the relevance of the difference between secondary and primary is that I told you, primary, commonest, related to age and risk factors. So, senang orang dapat, senang orang tak nak ambil ubat. Okay, and the one yang kita tengok hari-hari. But there is a small percentage of people, and these people are usually young, and there are causes, and these causes are treatable. When we treat, the hypertension go away. Now we're going to look at the cause quickly. Alright? The effects of prolonged hypertension is the same. But fortunately, secondary hypertension dia tak sempat prolong. Sebab kita discover, kita buang dia punya cause. Okay? Okay, these are the causes of secondary hypertension. It can be secondary to renal disease, it can be endocrine, vascular, drugs, alcohol, pregnancy, neurological diseases, and others. For example, increased intracranial pressure, psychogenic can lead to high blood pressure. Again, it's these factors that they role. Let's take kidney disease. I just told you prolonged hypertension, chronic hypertension lead to renal disease. But renal disease itself can lead to hypertension. Okay? People developing chronic kidney disease from other things, they can develop hypertension. Alright? So for example, chronic inflammation of the kidney, chronic glomerulonephritis, pyelonephritis, polycystic disease. Okay, you will learn this later. Just it's sufficient for you to know that chronic kidney disease at this point can lead to hypertension. How? Chronic kidney disease, when the kidney is damaged, there is reduced renal blood flow, right? Reduced renal blood flow. Summer, we're going back to this. Reduced renal blood flow. We're going back to the renin-angiotensin mechanism. The moment you have reduced renal blood flow, it will stimulate your renin-angiotensin mechanism, leading to aldosterone, leading to sodium water retention and vasoconstriction. Full stop. Okay? Right. So I forget about it. You can read on your own on the diagnosis because I have a meeting. Okay. This is an example of a kidney disease which a person is born with. It's called polycystic kidney. Okay? Some people are born with a tendency to form cysts, multiple cysts in the organs. It's genetic. It's inherited. Okay, this is called polycystic kidney, where the patient develops a lot of cysts in the kidney and damages the nephrons. Alright? The patient can have cysts in the liver, can have cysts in the brain, but more important is that the kidney is affected. Alright. Okay, I've told you about the mechanism, right? Okay. Now, apart from damage to the kidney itself, you can have diseases affecting the renal artery. You know, you have the renal artery from the aorta. You have renal artery that supplies blood to the kidney, right? So it's a medium-sized artery. So the renal artery itself can be affected by diseases. Okay, one of the diseases is called renal artery stenosis. Can be affected by atherosclerosis. Can be affected by fibrovascular hyperplasia. It can be an autoimmune disease. There can be embolism. So not necessarily you have a damaged kidney to reduce the vascular flow, but you can have a damage in the arteries that is supplying the blood to the kidney can be damaged. So again, the mechanism is the same. Reduce renal blood flow. Right.
Dia can stimulate the RNS,
renin-angiotensin, aldosterone, sodium water retention. This is an example of the renal artery which is narrowed because of a lesion in the wall. Okay. The next one is kidney, right? Now, endocrine disorders is a group of disorders that can give rise to hypertension. Okay, one of them is a tumor in the adrenal medulla. Okay, tumor in adrenal medulla that secretes catecholamines. You know what the catecholamines? You better know. What are catecholamines? Okay, so it causes high blood pressure, but characteristically it is paroxysmal, sometimes naik, sometimes turun, sometimes turun, and then it's associated with other signs and symptoms associated with increase in catecholamines. Okay, headache, sweating, palpitation, nervousness, nausea, vomiting. All right, this is so the key word here is paroxysmal fluctuation of BP. Increased catecholamines mechanism, catecholamine excess, which leads to vasoconstriction. Now, diagnosis. In the old days, we used to diagnose with this substance, which is excreted in the urine. But now we can measure the urinary metanephrine metabolites. That's how we diagnose. Very definitive. young man comes to you with these signs symptoms, you just do it. You suspect that a young man should be having essential hypertension. It must be secondary, so you investigate thoroughly. So you measure the 24-hour urinary nephrin metabolites, you get your diagnosis, you go in, you resect the tumor, it's okay. Alright? Now, this is a tumor. Okay? Cushing syndrome. You know Cushing syndrome, so I'm not going to elaborate because I'm running short of time. It's cortisol excess. Cortisol has got mineralocorticoid activity. Yes?
Yes.
Okay. Adrenal cortical tadi adrenal medulla. This is adrenal cortex. Tumor in the adrenal cortex. Okay, this is okay. The other hormone that can be secreted excessively from the adrenal cortex is your aldosterone itself. Okay, it can be caused by hyperplasia, it can be caused by adenoma. So this is called primary hyperaldosteronism. That's simple. Excess aldosterone, increase in sodium and water retention. The patient has hyperkalemic alkalosis. Alright. Acromegaly, growth hormone, excess too can lead to hypertension. Increase in total exchange of blood sodium. Again, it's related to sodium. Okay, and then we have congenital heart disease, coarctation of aorta. You have read your FLM?
Yes.
Have you read your FLM?
Yes.
You have congenital narrowing of the aorta and ligamentum arteriosum distal to the left subclavian artery. There is differential hypertension. Hypertension in the arm, but we can absent femoral pulse. Then there is a radial femoral delay. You go back and work out. Because of that, there is a reduced blood flow, and therefore, you understand ke I cakap cepat ni? Differential hypertension. Hypertension atas, bawah tak. So there is reduced blood flow to the kidney. So again, it relates. And then these are other things that can cause hypertension. Okay, you read on your own. Pregnancy is one. Drugs, of course. Alcohol, of course. Okay. Tak payahlah. This is just to show you this slide. Yeah. The slide that I wanted to show you earlier is just to this is what we do when patient comes with us with hypertension. Kalau dia elderly, memang kita suspect essential, kita tak akan investigate thoroughly. But if the patient is young and we suspect that it has a cause that can be treatable, then we investigate thoroughly. And this is why I'm showing you this. It's just for information. Alright? And then of course we investigate for hypertension. We not only investigate the cause, but for any hypertension, we want to investigate the effects. Heart okay ke, brain okay ke, kidney okay ke? Because the patient may come to you, bukan hari ni dia ada hypertension, besok dia datang. Tak. The patient may have had it for the last few years, dia tak perasan je. Tak rasa apa-apa. Bila the kidney is affected, baru dia datang. Bila rasa sakit jantung, dia boleh datang. So you investigate to establish whether he has complications or not. Okay? Alright, that's it.